Hello everyone. So today we will be doing two topics, biochemical pregnancy and ectopic pregnancy. From this class of 30 minutes, you are surely going to get one question in your November December exams. Okay, so do focus it on this class. After this class, you are going to attempt the PYQs on my Telegram channel at the rate DRRANAOBG. Okay, and you will also get extra expected questions as we did yesterday on these two topics. So make a strong hold on your topics and let's start it. Okay. Out of these two topics, biochemical pregnancy is more important. So I will be first discussing that. So let's study what is it, okay, and how the question comes. Here it is. So the clinical scenario which they give to you is that UPT is positive and the patient is suffering pain abdomen. Okay, UPT is positive and the patient is having pain abdomen, and on ultrasound nothing was there. Nothing means no adnexal mass, no uterine pregnancy, no adnexal pregnancy, and no uterine pregnancy. And on examination also all the findings were normal. Okay, so what we expect on examination is that in early pregnancy we expect either there will be adnexal mass or either there will be intrauterine pregnancy, so the uterus size will be large. So no, neither on the ultrasound we are getting any adnexal mass or the intrauterine gestational sac, and not on the examination also we are not getting any adnexal mass, and we are not getting any increased uterine size that we can say that yes, it is a uterine pregnancy. Now this patient who is having UPT positive, this patient is suffering the pain. Okay, now what to do for this pain, how to come to a diagnosis, which investigations we should order. Already on ultrasound there is nothing, and already on examination there is nothing. Now what is the next step? So before understanding you, let me tell you some normal physiology. Fertilization occurs, okay, then the beta hCG starts increasing. You all know after fertilization zygote is formed. Now this zygote divides and forms a trophoblast in a blastocyst. In the blastocyst, the outer layer is the trophoblast and the inner one is the inner cell mass. Okay, now the trophoblast, syncytiotrophoblasts cells. Trophoblast has two type of cells, cytotrophoblast and syncytiotrophoblasts cells. The syncytiotrophoblasts cells, they synthesize beta hCG, right? Now first step after the fertilization is that this beta hCG starts increasing. Okay, it start increasing from 0. First in the body there was no beta hCG. Now it starts increasing. Now this beta hCG, once it crosses the limit of 3500 international unit. Okay, once it crosses the limit of 3500 international unit, this limit, then a gestational sac can be appreciated on ultrasound. Okay, then the gestational sac can be appreciated on ultrasound, otherwise it will not be appreciated. Okay, so what is this in between stage? When the beta hCG, it was increasing from 0 to 3500, then in this stage there will be no gestational sac on ultrasound, and we will get no finding on examination. This is the stage in which only beta hCG is positive and no finding on examination and no finding on ultrasound. It means we are not getting any gestational sac on ultrasound. This stage is known as biochemical pregnancy. It means only beta hCG positive, no other findings. Okay, This stage is known as biochemical pregnancy, only beta hcg positive, but no other findings. So this will only be possible if beta hcg is less than 3500. Okay. Now what about our question? They say that patient has come to us with pain abdomen, and now what should be the next step? Okay, now there can be three prognosis of a pregnancy. Either it will progress as intrauterine pregnancy, or it will become an ectopic pregnancy if the implantation is on the tube, is in the tube, in the ampullary section, or it is an intrauterine pregnancy and it is aborting. How to differentiate in these three conditions at this time? At this time means when we are not getting any finding on ultrasound and on examination. At this stage, how we can differentiate? Okay, we can differentiate at this stage by serial beta hcg estimation. What do we mean by serial beta hcg estimation? It means that we will get the beta hcg done, and then we will repeat it after 48 hours. It means in the series we have to get the beta hcg beta hcg tested in the series. Okay, in the exam quite often they give you one beta hcg level and they ask you what next. What next? So what next cannot be solved on ultrasound, because on ultrasound nothing was there, and what next cannot be solved on examination, right? So now next is that we will get one more beta hcg done after 48 hours. Okay, after 48 hours of the first sample, we will get one more beta hcg done that will help us to differentiate the above three conditions. Okay, first condition is if it increases and it doubles in 48 hours. First condition is it increases and it doubles in 48 hours. It means this is a normal beta hcg increase. Okay, normal beta hcg doubles in 48 hours. This is perfectly normal and it happens in the intrauterine pregnancy. Okay, and it happens in the intrauterine pregnancy. If the beta hcg increase in 48 hours and the increase is exactly, it gets doubles, then it is a, yes, then it is a intrauterine pregnancy. If it increases but it does not get double, it means it is ectopic. It is increasing means the pregnancy is progressing. It means the pregnancy is progressing. Okay, but because in the ectopic pregnancy, the embryo or the zygote has got implanted on the tube. Tube is not a good as good as endometrium, right? Endometrium has lot of secretions, lot of favorable conditions for the embryo to grow, but tube is not. Tube is an abnormal condition. It is a abnormal place to get implanted. So their beta hcg will increase but it will not get double, right? So the answer is if it increases and it doesn't get double, it means that it is a ectopic pregnancy. Now next is if it decreases. If it decreases, it means that it is the pregnancy is failing. It means it is a abortion. Okay, so now the question which have they asked, keep the patient was having pain abdomen, how to find what is the reason for the pain? So there can be three reasons. Either it is having a normal the patient is having increased sensitivity toward the pain and the pregnancy is normal intrauterine, then the beta hcg will double in 48 hours. If it is ectopic, then beta hcg will increase but it will not get double in 48 hours. If the If beta hCG is decreasing, it means pregnancy is failing, it means it is a abortion. Okay, so last year we got a question on this condition in NEET PG. Last year we get in INS set. Now again it can be your number in the FNG. I'm telling you, it can be, it can come in FNG. Okay. Now next is uh, ectopic pregnancy. Okay. Now see, ectopic pregnancy, you all know the most common site for the ectopic pregnancy is the tube. Okay, so whenever we are talking about ectopic pregnancy, it means it is a tubal pregnancy, right? Okay. Next is that now in ectopic pregnancy, patient comes with these three symptoms. Okay, that it is a case of early pregnancy, patient has spotting and pain abdomen. These three symptoms patient come. Okay, now whenever patient comes with these three condition, that I'm having early pregnancy, spotting and pain abdomen, it can be only two diagnoses. Okay, number one, it is abortion case, pregnancy is getting failed, that is why the patient is having pain and having spotting. And number two is that it is a ectopic pregnancy, and that adnexal mass, the mass in the tube is stretching the peritoneum and causing the pain. Okay, so in whole medical science there are only two conditions for early pregnancy: spotting and pain abdomen, and this we differentiate between these two conditions on the basis of transvaginal scan. Okay, on scan, if there is a intrauterine pregnancy and if there are any sign of abortion, then it is abortion, and if there is adnexal mass, then it is a ectopic, right? So the three symptoms given by the patient: early pregnancy, spotting and pain in abdomen. Fix your mind this clinical scenario, only two differential diagnoses: either it is abortion or it is ectopic. Okay, and that also unruptured. Okay, because ruptured ectopic has shock presentation. Okay, now what if these three symptoms they are accompanied by shock, then you need not to think of any other cause, it is ectopic ruptured, it is a ruptured ectopic. Okay, then 101%, if early pregnancy, spotting and pain abdomen is coming in shock, it is a ectopic ruptured, because any abortion, if whether it is incomplete, whether it is inevitable, whether it is threatened, or whether it is missed abortion, or whether it is complete, any abortion it will, patient will never go into shock. Okay, so it is, patient is coming in shock, it means it is not a abortion, it is a case of ectopic pregnancy, and that also ruptured. My dear students, ruptured ectopic is a life-threatening condition. Tube has ruptured, lot of blood is being collected, patient will die if you are not going to treat this patient. That is why again and again in the exams they are asking you this clinical scenario: early pregnancy, spotting, pain abdomen, shock. Diagnosis, only one diagnosis in medical science, it is ectopic rupture, and it is an emergency life threatening condition, and they want you that you should know this diagnosis and you should save your patient in the coming future. Okay, okay, let me go to the next slide. So once you have diagnosed the patient that this is ectopic pregnancy rupture, you have to soon take the history Okay, what are the risk factors? You have to soon rule out to confirm your diagnosis, to establish your diagnosis. So first of all, I'm telling you what are the risk factors. The list is, this list is given more, the one who is on the top, the risk factor which is on the top will prone the patient more to the ectopic. Okay, so number one is history of previous ectopic pregnancy. Once ectopic occurs, then there are many chance, increased risk that again the ectopic will rupture. Oh, sorry, ectopic will occur, not rupture, occur. Rupture or non-rupture is in our hand. We can save the patient from rupture. Okay. So once again, I'm telling you, once ectopic occur, then the next time the patient will get ectopic, there are increased chances. Okay. Now, what are the risk factors which prone a patient to ectopic? Say it's primi gravida. Then what are the risk factors which prone a patient to it? Here I would like to tell you a very simple thing. You all know that fertilization occurs in zygote, and in the fertilization occurs in ampulla, in the fallopian tube, and this zygote then travels and get implant in the uterus. So the tubal problems will always lead to ectopic, the tubes problem, the fallopian tube problem. On the prime, the number one on the list is, infection, pelvic infection, that is PID or salpingitis. Okay, PID or salpingitis. Okay, that is number one. Infections, they don't let that zygote, the embryo, to move. They stop the embryo there only. Okay, so number one is pelvic infections. Number two is history of infertility. Why? Because in infertility, the major bulk is with tubal problems. Patient of infertility, major problem is tubal problems. That is why, though they are not diagnosed, but yes, infertility, female infertility is due to number one, ovulatory factor, number two, tubal factor. Do you remember? So number two on the list is history of infertility or infertility treatment. Hidden tubal problem is there in this patient. Number four is history of tubal surgeries. On a tube there is scar, history of tubectomy, history of tubal recanalization. If pregnancy occurs in them, then there are high chances that it would be a ectopic pregnancy, because there is a scar. That scar will not let the zygote move and implant. Number fifth, in the last, least priority is given to this history of failed contraception. Let me tell you how. Either the patient has gone into the permanent sterilization, then tubectomy we have read already, prones the patient to ectopic. Number two is, or the patient must have taken copper T. Copper T also prone patient to pelvic infection, we have read. PID was contraindicated, right? And then either patient have taken progesterone or combined oral contraceptive pills. Now the progesterone of the combined oral contraceptive pill and progesterone only pills, these both progesterone, what did they do? They decrease the tubal motility, right? We studied in combined oral contraceptive and progesterone only contraceptive mechanism of action. The progesterone, it decreases the tubal motility. So the history of failed contraception and always favors ectopic. First of all, you should know this fact that pregnancy does not occur once the patient is having contraception. You all know Pearl index of Pearl index of this copper T combined oral contraceptive, this tubectomy is zero point 0.1 tubectomy has 0.1 Pearl index, and copper T and combined oral contraceptive has 0.5 Pearl index, right? So low, so less, pregnancy is not going to occur. Then in case if it occur, then we have to rule out whether it is ectopic or not, because in both the conditions, in all the conditions, there are high chances. There is only one contraception which does not risk the patient to ectopic, and that is condom. Okay, because condom prevents pelvic infection, condom does not alter tubal motility. Okay, so condom does not prone the patient to ectopic, but you all know condom are useless contraceptive because they have so increased failure rate, right? Their Pearl index on typical uses 16 to 20. So it means out of 100 couples using the condom, the 20 of women will get conceived. So what is the use of such a failure rate, right? So though, but no doubt you should know the fact that condoms, they never risk the patient to ectopic. Okay. So these risk factor, all the tubal problems you will rule out. On the top, you will rule out if the patient is not primary. You will rule out that whether you are having any history of previous ectopic or not. Out of these, because previous ectopic will only in the second gravida, third gravida, the most common is pelvic infection. Okay, most common is pelvic, because in primary gravida, if there is pelvic infection, then ectopic will occur. That primary gravida patient will not give you the history of previous ectopic, and out of these, the least important is history of failed contraception, whether it is copper T, whether it is combined oral contraceptive, anything. Okay. Okay, now let us see how do we manage this patient has come to us with emergency. Patient has come to with three symptoms: pain, abdomen, vaginal spotting, early pregnancy, and shock. Now we know that this is a ruptured ectopic. We rule out the factors. Patient come out to be primary gravida, and patient said, yes, I had pelvic infection. Now what is the management? Okay, so let's see, we will see the management of all the patient, and we have to do it fast because it's a life threatening, ruptured ectopic is a life threatening condition. So there are, in all the ectopic pregnancies, they have three managements. Okay, number one is medical. Here we give injection methotrexate, which kills the fetus, but as it is a medical management, it will take some time to go and act on that fetus. So we have to see that whether we have that time or not. Okay, so as I told you, that time is never in rupture pregnancy. In rupture pregnancy, the tube is bleeding and bleeding and bleeding, intraperitoneal hemorrhage is going out. There we don't have time. At least it takes 1 to 2 days for this methotrexate to action. This methotrexate, it takes 1 to 2 days. So we have to see that whether it is, the pregnancy is not ruptured now, and it will not rupture in 1 to 2 days, then only we will give this patient methotrexate. And when this pregnancy ruptures, so we have to see that this is a small pregnancy. Okay, on an average, a tubal pregnancy ruptures at 6 weeks. Okay, but if the patient is of 4 weeks, it means the pregnancy is small. We have to have a proof of small pregnancy, that period of gestation is small, right? Then we can give this injection methotrexate, and then this will be successful. Okay, so if we are giving the medical management, we should have 1 to 2 days, so that our this medical management turned out to be successful. And if we cannot give medical management, okay, then there are two surgical treatments for the unruptured patient, unruptured ectopic in whom medical management cannot be given. The answer is salpingostomy. Now this is a surgery in which this is a fallopian tube, we make a opening we remove this because it is unruptured. It is done in an unruptured ectopic. We make a opening, we remove the fetus, and we close the abdomen. Just that. We are not going to close that the opening os which has we have created on the fallopian tube. We are not going to put sutures and we are going to close. Okay, so the surgery name is salpingostomy. It will be only done if it is unruptured. Okay, it will be only done if it is unruptured. And what is salpingectomy? Salpingectomy is remove the fallopian tube, and that is done in the case of the ruptured ectopic pregnancy, because once the tube is ruptured we have to remove the tube because we cannot save the tube. We have to do it in an emergency, whether it is primi or multigravida. Okay, we have to save the patient rather than thinking that its family is not complete. Okay, so these are the three management: medical management, surgical management, and there are two surgeries: salpingostomy and salpingectomy. Medical management, again I am telling you, it is only given if the pregnancy is unruptured and we have 1 to 2 days. So there we have to see that the pregnancy is of small period of gestation. Okay, now if all the criteria, we are going to read criteria now only. If all these criteria, the criteria does not fit of small pregnancy, then we are going to do salpingostomy. If it is unruptured, in salpingostomy we are going to make the opening, remove that pregnancy, and going to close the peritoneum. If it is ruptured, peritoneal bleeding is there, then no other solution. We have to remove the tube, that is salpingectomy. Okay, now what are the criteria to see whether the pregnancy is small or not? So here the mnemonic which you have to learn for the ectopic is 3-4. Okay, here the mnemonic is 3-4. Okay, 3-4 easy hai yaad karna, 3-4. Okay, so what is there? The gestational sac will be small, isn't it? If the pregnancy is small, then the gestational sac will be small. If the gestational sac is less than 4 mm, then 101% we are going, all the criteria should be met. If the gestational sac is less than 4 mm, then it means that the pregnancy is small and we have chance to give them injection methotrexate. We can save the patient from surgery. Number second, beta HCG less than 3000 international unit. In the starting only we discussed, if the beta HCG is progressing, if the beta HCG is progressing, right? Yeah, so if the beta HCG increase, it means it is an increased period of gestation. So the criteria is 3000 international unit. If the beta HCG is less than 3000 international unit, it means there is a time for the pregnancy to rupture. We can give injection methotrexate. And the next criteria is FHS absent. FHS comes at, you all know, it comes at 5 to 6 weeks. So FHS absent. And last is unruptured. Okay, unruptured, you all know, in ruptured we can't do in salpingostomy we can't do, then how we will do the medical management, right? Ruptured is, in ruptured the peritoneal cavity is getting filled with blood. We have to save the patient. Now no saving the tube, we have to remove. The tube has ruptured, the tube has teared. Now how we can save the tube, right? We have to do salpingectomy. No wait and watch giving methotrexate. We can't wait because peritoneal cavity is getting filled with blood, right? Okay, The investigations which can be we do is of course TVS. In the TVS we want that there should be an excel mass if we are suspecting ectopic, and there should be no intrauterine pregnancy. Uterus should be empty and there should be an excel mass. What are the examination finding? If it is a unruptured, then of course on if we touch the adnexa per abdominally, we touch the area where the adnexas are there in the inguinal, left right inguinal regions per abdominally, then a tenderness will be felt by us due to the adnexal mass. And on PV, because it is unruptured, in the uterus will be of normal size because the pregnancy is there in the adnexa, we will feel the adnexal mass. Okay. And if it is ruptured, now you all know that in the rupture, the tube has ruptured, the blood is get collected in the peritoneal cavity. Now this blood irritates a lot, then there will be increased tenderness, guarding and rigidity on per abdomen. And very peculiar sign which we see on PV in the rupture is that at cervical motion tenderness. In in OBG there are two conditions: chronic PID, severe PID, where we see cervical motion tenderness, because there also there are a lot of adhesions and peritoneum gets irritated. And another condition is ectopic. Okay, in chronic PID it's rarely asked. Usually if they are going to ask the question of cervical motion tenderness, they are going to ask of ectopic. And why there is cervical motion tenderness? Cervical motion tenderness means when we are doing the PV, cervix is moving, patient is feeling pain on moving the cervix, because when we move the cervix, the blood which is get collected in the peritoneum, okay, the blood which has got collected in the peritoneum, it further irritates the peritoneum, so patient feels the pain. Okay, on moving the cervix, the blood which is being got collected in the peritoneum, in the case of the rupture ectopic, it further irritates the peritoneum more and patient feels pain. That is the reason of cervical motion tenderness. And on the both the adnexa there will be fullness. Now we will not be able to appreciate any adnexal mass. Now as there is blood in the peritoneal cavity, both the adnexa, we will feel something fullness, liquid is getting filled, fullness in the both the adnexa. Okay. Now the one liners which do come, right? Okay, so now you all know most common is the tubal pregnancy. If it is ectopic pregnancy, okay, then tube has four parts: interstitium, isthmus, ampullary and infundibulum. I know I have been in contact with you from the last 2 months. I know you all know that interstitium is the late to rupture, because interstitial tubal pregnancy is supported by the myometrium. Isthmus is the earliest to rupture because it is the second most narrowest site, right? And ampullary is the most common site of ectopic, because here there are increased mucosal fold, and due to the increased mucosal fold, this area is prone to get infected. Okay. Out of all whole the tube, this ampullary area is more easily get infected because there is increased mucosa here. So most common site of ectopic is ampullary, and it is also the most common site of genital TB, and it is the most common site, sorry, and it is the site of fertilization. Okay, no questions come on infundibulum, we will not study this. Okay. Okay, second last slide. Ovarian pregnancy is the second most common pregnancy after the tubal pregnancy. Okay, the criteria is Spigelberg. Okay, again something to learn. I will give you a mnemonic here also. Okay, let's first study the another also. Abdominal pregnancy is the next pregnancy. If the embryo gets implanted in the peritoneum or somewhat, then the criteria is studiform. The peculiar characteristic of it is it doesn't rupture till 40 weeks. Okay, because in the peritoneum there is lot of space. Now how to learn that the Spigelberg is the criteria for ovarian pregnancy and studiform is the criteria of of abdominal pregnancy. See how I learn is, I will tell you. Okay, so there are basically two type of students: one student who gain the weight while they are studying, and one student who don't gain the weight. They don't lose also, they don't gain also, right? So there are two type of students. Okay, I am among those who gain the weight while they study. So abdomen gets increased while studying. Okay, so it is a studiform criteria. Abdomen get increased while studying. So studiform criteria. Okay, now there are some special persons whose abdomen or abdominal obesity doesn't come, who don't gain weight. They are special. Okay, so that is special is ovarian. Okay, now you all know, if weight is normal, then ovaries are normal, right? We studied in PCOS, right, that weight gain prones the patient to ovarian, polycystic ovarian diseases. So right, so the special persons who don't gain weight while studying, their ovaries will be healthy. So special, SP special persons is ovaries, who are studying and don't taking care of their health, are the abdominal pregnancy. Okay, that's all. Now the rarest pregnancy is the cervical pregnancy. The criteria which the thing which you have to learn about the ovarian pregnancy is, it is the second most common pregnancy, and the thing which you have to learn about the abdominal pregnancy is that it don't rupture till 40 week. And the thing which you have to learn about the cervical pregnancy is that once the cervical pregnancy is there, in the cervix the pregnancy is there, then it is going to bleed a lot. Okay, in from 10 weeks it start bleeding, until we remove the pregnancy it keeps on bleeding, keeps on bleeding, keeps on bleeding. So criteria is Palman and red, Palman and Rubin. So cervical pregnancy, I learn it as a I learn it like this: पूरा red हो जाता है, पूरा red हो जाता है, ठीक है, पूरा red, Palman. And this is the rarest, R for rare, R for cervical, and this is the rarest. Okay, till I was in PG, I haven't heard any case. In my post graduation, I handled one case of cervical pregnancy, and that patient also come with bleeding and bleeding and bleeding, keep on bleeding till we remove that pregnancy. Okay, okay, that's it. So and that is the criteria, and this was thing which was asked in NEET PG 2022. A patient came with massive bleeding per vaginal. Where is the implantation? Implantation is in the internal os, right? You will do all this question. Now last slide, 1 minute more. Heterotropic pregnancy. Heterotropic pregnancy means the pregnancy in which there are two pregnancy, one is ectopic and one is intrauterine. Now here we will only one thing you have to remember, that we are not going to give the patient medical management if the patient, because if the patient want to save that intrauterine pregnancy, then we will not give the patient medical management, because that methotrexate will act on the ectopic also and intrauterine also. So first, before giving the medical management, if we have diagnosed it and patient is eligible for the medical management, then we have to ask the patient that whether you want to save your intrauterine pregnancy or not. Okay, so medical management is only be given in the condition if the patient wants to, who don't want to save that intrauterine pregnancy. Okay, mostly this occurs in IVF. Ectopic, heterotropic pregnancy normally occurs in IVF, so they want their pregnancy, so we simply do salpingostomy, and the intrauterine pregnancy keeps on continuing very easily. Okay, that's all in the today discussion of biochemical pregnancy and ectopic pregnancy. See you soon on the Telegram channel. Okay, to practice MCQs and PYQs. Thank you.